Right. Okay. So this is the last section in cardiology. So let's finish off all the sort of arrhythmias, a little bit of pericardial disease at the end, not very important. Just a few concepts that I want to cover. Right. Now, just to remind you of what an arrhythmia is. So arrhythmia is essentially an abnormality of cardiac rhythm. Right. So there are two types of arrhythmias. On one hand, you have tachyarrhythmia, right? So you have a tachyarrhythmia. And on the other hand, you have a bradyarrhythmia, right? So these are the two main types of arrhythmias that you have. Now, as you know, in your sort of acute medicine discussions, we talked about various types of tachyarrhythmias, right? And essentially, based on the site of onset, tachyarrhythmias can be supraventricular, right? Where the tachyarrhythmia generation is from above the ventricles, and also they can also be ventricular, where the arrhythmia generation is from the ventricles. Right. Okay. Now, the first MCQ, and also for a more practical basis, when you're managing arrhythmias, we also divide this into narrow complex tachyarrhythmias and broad complex tachyarrhythmias. So just a revision of that very quickly. Right. So this, of course, is atrial fibrillation, and the first MCQ is on atrial fibrillation. Right. Now, the first two statements are on etiology of atrial fibrillation. Right. So here I have given you a list of causes of atrial fibrillation. Right. So as you can see, there are a list of causes. Of course, cardiac disease is a major cause of atrial fibrillation. And in Sri Lanka, we see a lot of sort of mitral valvular disease related to atrial fibrillation. Right. But of course, you can have atrial fibrillation in other cardiac conditions as well, as are listed here. Right. But remember, for MCQs, we can also ask you the sort of non-cardiac causes of atrial fibrillation, right? Like alcohol intake. So acute alcohol ingestion as well as chronic use of alcohol can both cause AF, right? And hyperthyroidism is a very well-known cause of AF. So just to keep an eye on these. And the incidence of AF increases with age, as you can see in this graph here on the left, right? So this is an important thing, just to go through a list of causes of atrial fibrillation. Right. So occurs as a consequence of acute alcohol excess. So both in acute alcohol ingestion as well as in sort of long-term alcohol use, you can get atrial fibrillation. And the incidence, as you can see in that graph very clearly, increases with age, right? So there is an increase in age with atrial fibrillation. Right. Okay. Then what is the characteristic ECG abnormality in atrial fibrillation? You see the sort of irregular baseline, right? That is the typical appearance that you see, a completely irregular baseline, right? Where you cannot make out clear-cut P waves. You can't make out clear-cut P waves. There is an irregular baseline, right? There is an irregular baseline and you cannot make out clear-cut P waves. Right. And of course, the RR intervals are irregularly irregular. A sawtooth P wave is seen in patients with atrial flutter, right? Atrial flutter, and this is what it looks like, as you know by now, right? So the sawtooth P wave is in atrial flutter. Right. Now, atrial fibrillation, clinically, what we do is we detect it as a completely irregular pulse, which usually does not regularize with exercise, right? Sometimes you can feel an irregular pulse when there are multiple ventricular ectopics, right? So when there are multiple ventricular ectopics, sometimes it can cause an irregular pulse. But remember, these ectopics usually disappear with some sort of physical exertion. So the pulse sort of comes back to normal with exercise. This phenomenon is not seen in AF, right? So that is the fourth statement there. The last one, of course, you have to know at this stage. What happens in atrial fibrillation is the atrium does not contract properly. So there is no effective, nice contraction of the atrium. This causes stagnation of blood in the atrium. Now, as you know, whenever there is stagnation of blood, that can give rise to the formation of a thrombus, right? That can give rise to the formation of a thrombus. And then, of course, these parts of this thrombus can embolize into the brain, causing strokes and TIAs. And this is where we talk a lot about anticoagulation in AF, right? That's a very important thing that we do. And this is to reduce the risk of this sort of stroke and TIA. So because of the stagnation of blood in the atrium, you get formation of clots which embolize into the brain, right? So that is the problem there. Okay. So this is AF. Okay.
So can you explain the fourth statement again?
Fourth statement. So in AF, there is a persistence of irregularity in a patient with AF. So even if you ask the patient to walk around a little bit, the irregularity will not change. But if the patient has multiple ventricular ectopics, that also can cause an irregular pulse, but that doesn't change with exercise, right? Paroxysmal AF is obviously something that comes and goes, right? So there are some people get maybe a few hours of AF and then it spontaneously disappears, right? There is no relation with exercise or anything with that, right?
Thank you.
Okay. Right. Now we come to the management of AF, right? The management of AF. Now, again, I've taught you this in your medicine appointments in the acute medicine classes. Essentially, the bottom line is, if your patient is hemodynamically unstable, right? Or remember those adverse features that we discussed, right? So what are the adverse features? Shock. Significant myocardial ischemia related to the atrial fibrillation. Syncopal episodes. Or acute left ventricular failure, acute heart failure, again related to the AF. If any of these adverse features are present, regardless of when the AF started or how long it has been going on for, we have to offer the patient a synchronized DC cardioversion, right? So that is very, very clear. So regardless of when it started, what the cause is, you have to give the patient a DC cardioversion, right? Or electrical cardioversion, right? That is if the patient is unstable or having any of those adverse features, right? Any of those adverse features. Okay. Now, if the patient is stable and does not show any of those adverse features, then of course, the time of onset of AF comes into play quite a lot, right? Time of onset, the time of onset, right? So if the time of onset is very, very clear and you are absolutely sure the AF onset is less than 48 hours, right? We offer either a rhythm control strategy or a rate control strategy. As you can see in this picture, we can offer either a rhythm control or a rate control strategy, right? How do we decide on this, right? So rhythm control strategy is actually better for people who are young, right? And have structurally normal hearts. So in a rhythm, so that works a bit better for those sort of people, right? So people who are young have a structurally normal heart, so they don't have valvular heart disease, for example, right? Those sort of people, this rhythm control strategy works quite well, right? And that can be either with a DC shock or with medication, right? Medication, and the two drugs which we commonly use are amiodarone, or there is another one which you don't have much in Sri Lanka, which is called flecainide. So those are the drugs that we use for rhythm control. So rhythm control is better in these people who have structurally normal hearts and are young. All other people, we will offer a rate control strategy, right? Rate control strategy. Beta blockers are commonly used. Calcium channel blockers are used. And also digoxin is useful in patients who have a heart failure, chronic heart failure. Or if their blood pressure is a bit marginal, digoxin is a useful drug to use. Right? Digoxin is a useful drug to use. Okay, so those are your sort of rate control strategies. So if your onset is less than 48 hours, you have this option of either going for a rhythm control or a rate control. Of course, if your onset is more than 48 hours, then your approach would be a rate control strategy. You would not usually go for a rhythm control strategy. The reason is the longer the AF has been going on for, the risk of thrombus formation is high. And the moment you convert them into sinus rhythm, they are at a high risk of developing strokes. When you convert into sinus rhythm, they are at a risk of developing a stroke. So that is the problem, and that is a concern. So what we do is you offer them rate control, right? And then at a later point, right, later on, maybe in a few weeks' time, we can consider a delayed rhythm control strategy, right? A delayed rhythm control strategy, right? And if you are going for that, we put them on anticoagulation, right? Until that is so, after about 4 to 6 weeks, we get them back to the cardiology unit most of the time, and they do a delayed rhythm control strategy. But you put them on an anticoagulant until that happens, right? Okay, so this is your main sort of approach in the management of AF. So using this knowledge, now you can easily answer statement 1 in this MCQ. Stable patients, immediate electrical cardioversion is not the preferred option. So in order to do electrical or whatever cardioversion you're doing, the one thing is that the AF should have lasted less than 40. It should be absolutely clear that the onset is within 48 hours. And the second thing is, the second important thing to notice here is that the patient should be in that group of patients who have a structurally normal heart and they're young, right? Those sort of patients do much better with electrical cardioversion. So that is important, right? So that's false. Digoxin is the preferred agent for control of the ventricular rate. Not really. Beta blockers are what we prefer, but digoxin is useful if the patient has heart failure, chronic heart failure. If their blood pressure is a bit marginal, digoxin is a useful drug to use, right? Also, digoxin, the problem with digoxin is it doesn't control the heart rate when you're, say you have AF and you're sort of exerting yourself, right? It doesn't control exercise increases or exercise-related increases in heart rate, right? It controls the sort of resting heart rate very nicely, but doesn't control the exercise-induced increase in heart rate, right? So that's a slight limitation, but it's very good for patients with heart failure, right? AF and heart failure. All patients with AF should be commenced on anticoagulation, right? So that's again false, right? All patients with AF should be commenced on anticoagulation. False, obviously. So most of the patients, except patients with significant mitral valve disease, you have to use the CHADS-VASc score to make this decision. We talked about this briefly on Thursday. So patients with significant mitral valvular disease, especially mitral stenosis, is a different entity. All other people, we use the CHADS-2-VASc score to make decisions on anticoagulation. So that is one important point to remember. We also use shorter periods of anticoagulation in certain situations, right? Shorter periods of anticoagulation. One is if you have cardioverted somebody, right? So the main indication is CHADS-VASc or significant mitral valve disease, especially mitral stenosis. That's one. Second one is that shorter periods of anticoagulation are indicated around cardioversion. So when you're cardioverting somebody, remember that when the atrium starts contracting again, like it was a bit stagnant, starts contracting again, there's a little bit of a risk for stroke, little bit of a risk. So for about 4 to 6 weeks in patients who we cardiovert, we continue a bit of anticoagulation for a few weeks, even if they don't meet that Chance-West criteria, just to cover that period, right? Cover that period of cardioversion. The third indication for anticoagulation in AF, you have seen in this algorithm, if you are planning a delayed rhythm control up to that period, you will also give some anticoagulation, right? Again, that cover is what is important there. So 3 indications for anticoagulation AF. One is long-term, obviously, if they meet the criteria for the Chance-West cough, they have significant mitral valve stenosis, mitral disease. For a shorter period of time, if you are doing a cardioversion or planning for a cardioversion, you would give a shorter period of anticoagulation. Right. So that is about anticoagulation. The fourth statement is aspirin is no, there is no place for aspirin as an alternate. It doesn't work. It is not recommended. As an alternate to anticoagulation, no, there is no evidence that it works. Right. A long-term rhythm control strategy has a better outcome than rate control combined, and there is no evidence to that effect. එහෙම ලොකු evidence එකක් නැහැ. ඒ දෙකේ ලොකු වෙනසක් තියෙනවා කියලා. There is no evidence. That is slightly advanced MCQ. I just wanted to teach you that whatever strategy you go for, right, either a rhythm control strategy or a rate control strategy, it doesn't make much of a difference ultimately. ලොකු වෙනසක් නැහැ. There is no big difference in whatever approach you take. මේ algorithm එකේ මොන approach එක ගත්තත් ලොකු වෙනසක් නැහැ. The only thing we are worried about is you have to make sure that you don't create a stroke. That is the most important thing. Hari. Any questions about this MCQ?
Sir, when you rate control someone, if there is no huge benefit between rate control and rhythm control, why do we get them back on a later day and rhythm control?
So benefit කියන මෙතන benefit means sort of things like mortality benefit අරක මේක ඒ වගේ දේවල්, right? But obviously there is a slight risk of stroke, no, if you have AF, whatever it is, right? So you are trying to judge for that, right? So if you, of course, if you are suitable to have no AF, that is good, no? Even though the evidence is not strongly good for that. So that is why we do it, right? So if you have a good heart, structurally normal heart, you would prefer to be in sinus rhythm than in AF, no? Right? Why we don't try? So in patients who have valvular problems and structurally abnormal hearts, even if you try to cardiovert them, they will revert into AF. So there is no point in wasting time on that. Yeah. But of course, you would be comfortable. The patient will be comfortable if they don't have AF, no? And even that small risk of stroke is not there then. Yeah.
Right, sir. And also, sir, in the same vein, young patients who we are pretty sure they have AF less than 48 hours, do we prefer to rhythm control?
ගොඩක් වෙලාවට yes. ගොඩක් වෙලාවට. But again, it depends on who manages the patient really. Hari? The guidelines are not very clear as to do this කියලා. Nobody sort of forcing you to do it. It all depends on a patient-to-patient basis, patient choice, and who is managing the patient, that sort of thing. Yeah.
Right, sir. Thank you.
Okay. So, Kanish, no, you don't need to know the Chance-West score by heart. Don't worry about that. That's not required. Yeah. ඉතින් මොනවද කියවෙන්නේ කියලා කියන්නේ ඕකේ ස්කෝර් එකේ මාක්ස් කීයක් දෙනවද කියලා that sort of thing we will never ask you. Yeah.
Sir, in unstable patient, we are going for DC, right? So in that case, also we have to do anticoagulation.
Yeah, for a shorter period, even if you don't fulfill the Chance-West thing, a short, say, for few weeks of anticoagulation just to cover that effect until the heart sort of completely recovers and you give a shorter course of anticoagulation. Yes, that's right. Yeah.
Thank you, sir. So is it heparin? No?
So in hospital, it is heparin. And then when you discharge the patient, you can give a few weeks of warfarin. Get them down about a month and talk to them, and you can take it off if they don't meet the Chance-West score, other criteria for long-term anticoagulation.
Okay, sir. Thank you.
Hari. So, Samatha, rate and rhythm control dekama karanna avashya naha. If you do rhythm control, automatically the rate is back to normal, ne? So, yeah. So that is, yeah. But remember, when it's more than 48 hours, you don't do rhythm control because of the risk of stroke. Because the moment your heart starts pumping back normally again, our Tibba clots can break off. That is the problem. Yeah. Yes, again, so in emergency cardioversion, again, whatever, when you are doing a cardioversion, you need to anticoagulate them for a short period of time because එතන transiently පොඩි risk එකක් තියෙනවා stroke වල. When you convert them from AF to sinus, there is a transient risk of stroke. So we do give, whenever you are anti-cardioverting somebody, we give a short course of anticoagulation for that patient. And if they fulfill the Chan's-Fasko other criteria, then long term after that. Yeah. Hari. So coming to this one, Metana Katandare, this is a slightly tricky MCQ, and there are several ways in which you can argue this. And of course, we might even give marks for 2 answers in this because it's slightly, you can argue whatever way you like here, right? So the main thing here is that the patient has sort of presented with acute illness, right? It seems like this patient is thyrotoxic and sort of presenting with AF. So what would you do here? මොකද්ද මෙතන කරන්නේ? And why? Bye වෙන්න එපා. Just somebody say. Or type, if you like.
Rate control, sir.
Okay. Why?
Because so I said earlier, rhythm control is for young patient with structure in normal heart, and this patient seemed to have precipitant also. Thyrotoxicosis, seems like thyrotoxicosis.
Yeah.
So and she has features of heart failure too. So
yeah, so if there's heart failure, what might you do? So isn't that adverse feature? මොකද හිතන්නේ again?
So can we use digoxin because she has heart failure?
Okay, reasonable. Okay. Any other answers?
Since she's having heart failure, we consider it as unstable.
Yeah, so that's a good argument to use. So this patient is a 65-year-old. There is acute heart failure. Patient is unstable. So the first thing you would do is cardiovert, right? So that is the most acceptable answer here, right? But remember, there is another very important point that has to come with that. And I think you touched on that. The patient is thyrotoxic also, right? So even if you cardiovert, you have to start the patient immediately on something for the thyrotoxicosis. So what is the best thing to do there? So cardiovertical, to control the thyrotoxicosis, you need a beta blocker, right? So here, the best answer is cardioversion on the basis that the patient is hemodynamically unstable or considered to have adverse signs of AF, right, of heart failure. But remember that you have to give the beta blockers as well. As soon as you cardiovert, you have to give the beta blockers, because the beta blockers, as you know, will control the thyrotoxicosis. And we'll talk about this later in endocrinology. It controls the heart rate on a long-term basis. Also, it stops the peripheral conversion of T4 to T3, right? So it has an effect on the thyrotoxicosis also, right? So that is the sort of sequence of events. So it's a very difficult MCQ, but you can argue for DC cardioversion because the patient has LVF. Right. Hari. Right, make copy. So I've just given you in these slides the Chan's-Fasko criteria, and how you start anticoagulation based on the scope, right? Right. So that is just for your reference. Okay. Right, next one. Let's try this one. So what is the answer here? මොකද්ද මේකට කරන්නේ අපි? So there is no adverse sign here, right? Just a patient coming with a bit of dizziness, right? And atrial fibrillation. So what would you do here? And we don't know when this started as well. නේද? ඒතර මොකද්ද මෙතන කරන්නේ අපි? කමන්නේ බයින්ව කතා කරන්න. That's when how you learn.
So since this is a old lady and we don't know when she started AF, we cannot be sure of the time cutoff.
Yeah.
So it would be advisable to rate control her as opposed to rhythm control.
Good.
So I'd go for rate control, preferably with digoxin, and give long-term anticoagulation.
Right, that is the answer. Why digoxin specifically?
Because since she's 80 years old, and her blood pressure is also not too high, I'm worried about it crashing with the beta blocker.
It's not a big problem. 138 is a reasonable blood pressure. You can give beta blocker. It's not completely off, right? You can start with a lower dose of beta blockers and titrate it. It's not a big problem there. Right. So, but yes, it is rate control plus anticoagulation is the answer. Also, you can see that apart from this, when the patient is elderly, there is some structural change in the left atrium. So, there's an enlarged left atrium as well. So, of course, the better option here would be for rate control rather than go for a cardioversion strategy. Yeah, good. Hari, any questions about that? So, Nimesh, digoxin has a bit of a problem when you are using it. So, if you are using digoxin, the problem is takes time to start working, right? So, you have to use something called a loading dose regime, right? Loading dose regime for that. So, for the previous question, it doesn't always have to be a non-selective beta blocker, right? Even something like metoprolol will help with the thyrotoxicosis, right? Ek loku problem එකක් නැහැ. Propranolol වෙන්න ඕනේ නැහැ. හරි. Okay.
Excuse me, sir.
Oh.
The second question with the heart rate of 80 also, do we need to rate control the patient?
Oh, no. ඒකේ තියෙන rate control long term rate control strategy එකද. මෙතන ventricular rate was controlled with a beta blocker. So we are going to continue that and anticoagulate. ඒකයි කියන්නේ. හරි?
Okay.
So that's why the Nipun has asked the same question. So essentially, the patient has been given a beta blocker. What we do is we continue it, right? It says continued rate control. ප්‍රශ්නේ තියෙන්නේ beta blocker එකක් දුන්න ගමන් heart rate එක අඩු වුණා කියලා. So you continue rate control and anticoagulation. That's what the statement says there. Yeah. Hi. Okay. So now we talk about supraventricular paroxysmal supraventricular tachycardia. Right. Now, this type of arrhythmia, right, can mechanistically occur in two situations. Sorry, two situations. One is there is a sort of a accessory pathway or a circuit that includes the AV node, right? So that this type of arrhythmia, paroxysmal SVT or SVT කියන arrhythmia එක can be due to a circuit, a rhythmogenic circuit involving the AV node, right? So that is called AVNRT. So that is mechanistically that is called AVNRT. Another way that this can be generated is if there is a abnormal connection between the atria and the ventricle. So something like in Wolff-Parkinson-White syndrome, right? So that is a different thing that is called AVRT, right? So it is a different connection pathway between the atria and the ventricles. But most of the time it is due to this abnormal circuit around the AV node, including and around the AV node, right? So statement 1 is false because most often that is the atrioventricular nodal circuit rather than atrial ventricle connection. Right? So an accessory pathway connection. So that is a different thing. Right. Now, as you know, so SVT, so most often this is actually due to AVNRT, right? Most often, right? Right. So what it commonly causes is a arrhythmia like this, a narrow complex tachyarrhythmia, right? Narrow complex tachyarrhythmia, regular, as you know. Right? So make it Veradi. That's wrong. Vagal maneuvers are contraindicated. Now, you know the management of these patients. So the management is simply this. Again, if the patient is unstable, we know that the patient will need a cardioversion approach. If the patient is stable, what are the things we do? Remember, I taught you this. Vagal maneuvers first, failing which adenosine, right? And then if adenosine, you can give up to 3 shots of adenosine. If the adenosine also is not working, then you can try various things. Some people use calcium channel blockers, or you can go for cardioversion also. Right? So if your shots of adenosine are not working, your third line options would be cardioversion or IV calcium channel blockers also. See, people sometimes use, right? IV calcium channel blockers. Right. Okay. Right. So vagal maneuvers are contraindicated is false, right? Intravenous calcium channel blockers are first line therapy is also false. It is the adenosine that is a first line drug, right? And flecainide is not used in this arrhythmia, but it can be used in atrial fibrillation, right? But remember, flecainide is contraindicated, right, in patients with structural heart disease. Man metana flecainide ganama vachanayak kiwa mena metana, yeah. So you can see flecainide. Yeah, it can be used for rhythm control in AF, right? The main contraindication for flecainide is you cannot use it in patients with structural heart disease. So metenta echara adala naha, but if you asked about flecainide, that is the problem. Okay. So that is this MCQ. Pungavi, chemical cardioversion in the previous context is when you use something like amiodarone or flecainide to cardiovert a patient with AF, right? Right. So this is it. So what we call paroxysmal supraventricular tachycardia is most often this AVNRT business, right? AVNRT is this abnormal circuit, arrhythmogenic circuit, which includes the AV node, right? So that is that. Right. Any questions about that?
So how do we know whether it's a AVRT or a AVNRT?
Oh, yeah, that's a very good question. The only way possibly to know is after you get the patient back into sinus rhythm, right? So AVRT, then you will see this delta wave, right? That's a bit of an advanced question, but that's fine. So sometimes it is impossible to tell them apart on an ECG alone, right? On an ECG during the arrhythmia, it is very, very difficult, right? So most of the time, the diagnosis is made in retrospective. So when the patient improves back into sinus rhythm, then you will see the delta wave if it's AVRT. Also, rarely this AVRT can give rise to a broad complex tachyarrhythmia, which has a very specific appearance. Right? Eka again is a bit too much for you. Of course, if you do medicine for postgraduate, then you will learn about it. Right? But that is a difficult thing. Right? Sometimes it can cause a broad complex tachyarrhythmia. There is a special appearance of that. Right? So those are little too advanced concepts, but it's sometimes impossible to say on a arrhythmia ECG. You have to take the patient back into sinus rhythm, and then you will start to see the delta waves in the AVRT. Okay.
Okay, sir. Thank you.
Hari. Right. Question number 4. Now, this I included because I saw it in one of your papers. It's not something that we all worry too much about at undergraduate level, but just because it was there, I will just teach you. Now, we talked about this broad complex tachyarrhythmia when we were doing the appointment. Eh? I told you that your approach to arrhythmia management would be narrow complex, broad complex. And I told you that broad complex tachyarrhythmias can be due to two reasons. One, it is due to a ventricular tachycardia. Could be due to a ventricular tachycardia. Or it could be due to a supraventricular origin tachycardia, which comes from above. But there is a conduction block. There is a conduction block. Right? There is a conduction block in the pathway. That can also give rise to a broad complex tachyarrhythmia. So if somebody asks you what are the causes of broad complex tachyarrhythmias, one is ventricular tachycardia, right? And then two is, so one is ventricular tachycardia and two is the, if there is a supraventricular tachycardia with a conduction problem, a block along the pathway, then again the QRS complex will widen a little bit, right? So that is that, right? Okay. So there are ECG features that are characteristic for the right? So is this a ventricular tachycardia or is this a, we call those, the second thing, aberrant conduction, right? So SVT with aberrancy කියලා කියන. ඔය දෙක අතර වෙනස අඳුරගන්න there are some ECG features. And 5 of them are in this slide, right? Essentially, the QRS will be very, very broad if it's VT, right? So more than 140 milliseconds. Also, there will be extreme axis deviation. That right side deviated axis, right? I won't go into these things because they are like but extreme right axis then or extreme northward axis right. Then another feature which is obviously easy to understand is because the ventricular tachyarrhythmia is independent, it is a complete heart block then ventricle. The ventricle is running the show. So there's AV dissociation. So what happens is if you look carefully, the P wave has no P waves but they don't have any relationship between the QRS complex because the ventricle is now running the show. So there is AV dissociation. AV dissociation. Occasionally, those are this is very interesting. Occasionally, this is what is happening. The ventricle is running a show, but right? The P wave from the sinus node, there are impulses coming down which are dissociated with the ventricle, but occasionally you can see one or two of those and they can be seen like this. ECG fusion beat. So fusion beat. Sometimes you see, so it's fusing with a QRS complex or abnormal VT එක fuse වෙලා තියෙනවා. Or වෙනමම පේන වෙලාවල් තියෙනවා මෙහෙම ලස්සනට. Right? That's called a capture beat. Right? So fusion beats and capture beats. පේනවා සමහර වෙලාවට. Right. So because some of those are උඩින් එනවා එකපාරට පේන්න ගන්න සමහරට. In between that big mess where the ventricle is firing, you can see some of those leaking through. Some of the normal beats leaking through from the SA node. So those are called fusion beats and capture beats. Right. Okay. So these are ways of differentiating a proper ventricular tachycardia from all of those other supraventricular aberrant conduction ones. Both of them give rise to a broad complex tachycardia. Another feature, short appointment concordance is another feature. In VT, all the QRS complexes will be in the same direction. SVT with aberrancy. So this is concordance. Then MCQ, so all the QRS complexes in the same direction. The MCQ broad QRS complex. Then මෙතන ඇත්තට මම හරියට මේක නම්බර් එකක් එක්කම දෙන්නම් more than 140 කියලා හදාගන්නකෝ ඒක broad එක ඉතින් දෙකම broad නේ හරි so capture beats yes irregular rhythm doesn't necessarily suggest a VT over a SVT with aberrancy because හිතන්න AF එකක් එක්ක aberrant conduction එකක් ආව කල you get a irregular rhythm so yeah and VT is usually a regular rhythm හරි So that's wrong. AV dissociation, yes, in a VT, because the ventricle is running the show, there is AV dissociation, and concordance is also a feature of a PT, right? All the QRs, the make balan, all the QRSs will be in the same direction. Right. Any questions about this one? So that is why I put this in. Yeah. Hari. Any questions about that? Customer hai teenwa there. Hari. Okay, fine, good. Right. Complete heart block. So all of you know what a complete heart block ECG looks like, neither, right? And we have gone through this during your appointment. The main feature of a complete heart block is, right? The main feature of a complete heart block is that there is atrioventricular dissociation. Ne? So because the AV node is blocked, the ventricle starts generating something called an escape rhythm. So that is an escape rhythm. And then that functions completely independently to the atrium. So there is an atrioventricular dissociation in a complete heart block. Right? What are the symptoms of complete heart block? These patients present with bradycardia and sometimes syncopal episodes, right? Syncopal episodes. Now, an interesting sign you see in complete heart block is something called a Canon A wave. ඒ මොකද ඒක වෙන්නේ because so A wave, as you know, is caused because of atrial contraction. මෙතන මේක තියෙන්නේ හරි. Right. The atrium contracting against the opening tricuspid valve. Right. Now, in in complete heart block, because the atria and ventricles are completely dissociated, සමහර වෙලාවට the atria and ventricle contract together. එකම වෙලාවට contract. Now you can imagine that the atria is completely on its own, ventricle is completely on its own. Sometimes they contract together, which should never happen in a normal person. Atria and ventricle contract together. That causes a sudden elevation in the A wave of the JVP. Because එක contract now, massive pressure එකක් එනවා, and there will be a spike in the A wave of the JVP. So massive spike in the A wave of the JVP. Right? A massive spike in the A wave of the JVP. So that is called a Canon A wave. A Canon A wave. Also, because of this same concept of the atria and ventricle sort of dissociation, මොකද වෙන්නේ? First start sound intensity is also variable. නේ? ඔක වැහෙන්නේ, the S1 is generated because of valve closure, right? And because the atria and ventricle are functioning independently, the valve closure එකත් එක එක වෙලාවට එක එක විදිහට වෙනවා. The pressures change, right? For valve closure. And that is a variable intensity of the first start sound. Again, because of this dissociation. So the impact of the dissociation will be seen in the Canon A wave of the JVP and also this variable intensity of the first heart sound. Hi. So true or false regarding complete heart block? Canon A waves, yes. Syncopal attacks, yes. And we know that the main thing is the dissociation of the P waves and the QRS complexes, and varying intensity of the first start sound. So those are all true. Right. Now let's come to this one, and then you can ask questions if you have any about this. Now, this is very important, right? So, this sort of cartoon tells you what happens in a patient with a complete heart block, right? So, in a complete heart block, the ventricle is generating its own rhythm. The ventricle is, because nothing's coming from above down, the ventricle is generating its own rhythm. Now, this rhythm can be generated here, right below the block, or can be generated there, distally, away. Right. We now know that, or we've known for a long time, that if the escape rhythm is generated closer to the AV node, it is very close to normal. Very, very close to normal. Right? Very close to normal. And that has a better prognosis. Whereas when it's right out here, right, in the ventricular muscle, it can never generate, as you know, physiology to Gannati, the ventricular muscle can never generate a rhythm above, say, about 30 or 40 beats per minute. Right? So that will be significantly slow and the prognosis is extremely poor. Right? So the prognosis is extremely poor. Right? So that is that. Right? That is this problem here. Right? So the ventricle will start generating its sort of own rhythm, and where it starts, where the escape rhythm is commenced, is important. So closer to the AV node, just below the AV node, good prognosis. And it causes a normal looking QRS complex, a narrow QRS complex. At when it causes a broad QRS complex, because the QRS complex morphology changes to a very broad thing. If it arises, it's almost like the normal. So they can go in the normal way. So actually, let's go back to this MCQ. If it's broad, it is poor prognosis, right? So, narrow nam poor කියන එක වැරදි. So this is false. Sorry, right? So narrower means it's generated closer to the normal and it is better prognosis. Broad and it's generated in the distal cardiac myocyte, which is obviously not very good. Hari, any questions about that MCQ on complete heart block?
So that first stem, the Canone waves are seen on the JVP.
JVP. Sorry. ඒක හදාගන්න. ඒක that's a typo. It should be JVP. Yeah. Right. Okay. Right. And just a revision of this, remember, bradycardia management is very similar to tachycardia management when it comes to adverse features. So you're looking for the same types of adverse features. If the patient has any adverse features, you need to manage the patient medically, right? And atropine is the drug of choice there that we use. Sorry, atropine, no, there are other options also, but atropine is the main drug. Now, important to note here, this is very important. There are four, I told you this during your appointment, there are 4 high-risk bradycardia ECGs, right? And one of them, as you can see, is complete heart block with broad QRs. Even though they don't have any adverse features, that is still high risk of asystole and death. So again, putting together that prognosis, the broader it is, the prognosis is poor. Sorry. And also, MCQ a long ventricular pause. So sinus beat without any ventricular response for more than 3 seconds. Morbid type 2, you know what it is. Or if when you're recording the ECG, you see a recent evidence of asystole, right? Asystole, right? So those are the things that you look for. And they are all high-risk ECGs, should be managed medically or sometimes use pacing, transcutaneous pacing in the ward. Right. So that is just a quick revision of bradycardia management. So that is about arrhythmia.
So, a broad කියන්නේ is there a cutoff?
Broad කියන්නේ so it's more than 5 small squares, right? So usually 3 to 5 QRS complex. If it's more than that, that's broad. Yeah.
Now, again, so that make it in complete heart block with broad QRS means all complete heart blocks will have a broad QRS. No?
So there's a complete heart block and the escape rhythm is broad. Right? If the rhythm is generated close to the AV node, it's not broad, it's narrow. It can go dark broad because it's closer to the normal. Yeah?
Yeah, okay, sir, got it.
Atropine is not contraindicated in Mobitz type 2 heart block. No. Right. Hari. Okay, so let's move on to pericardial disease. Now, these are just a few MCQs at the end, just to cover off some things. If at all you'll find 1 or 2 MCQs of this whole thing. Right, so acute pericarditis, these are the causes, right? So again, just to familiarize yourself, because the MCQ will samani patan ganne cause ekak ahala. So just again, these slides are important because මේවා ටික විභාගෙට යන්න කලින් පොඩ්ඩක් බලාගෙන ගියොත් එහෙම I think you will have a good coverage of all the topics that you know. You can't study the whole command class before you go for the exam. So these slides that I've selected to put in are sort of useful for you to cover just before you say විභාගෙට දවස් 3-4ක් විතර තියලා මේ ටික බලාගත්තා නම් ඇති ගොඩක් දුරට MCQ එකට. හරි? So these are list of causes, and viral pericarditis is extremely common. Coxsackie virus is a famous virus that causes pericarditis. Hari. Acute pericarditis, chest pain is a feature. Yes, that is true, but it is relieved when the patient sort of bends forward, right? So that is wrong because of that reason. Now, if you look at so relieved on bending forward, chest pain relieved on bending forward is pericarditis pain. Hari. Now, if you look at the ECG, what you see, it's very difficult to catch this, of course, on an ECG. There are two things. One is that there is PR segment depression. That is one feature of a pericarditis. So PR segment depression. And also sort of diffuse ST elevations in all the leads, right? So it's not localizing to a particular coronary artery territory. In all the leads, you will see ST elevations, and the other features you can see. This is the PR segment depression, right? PR segment depression. Right. Correct. So this is right. Hemorrhagic pericardial effusions are seen. Uremic is true, and also in malignancies also you see hemorrhagic pericardial effusions. What do you use for management? The famous drug we use is colchicine, right? Sometimes we use NSAIDs also, but colchicine is what we prefer to use in pericarditis, acute pericarditis. Hi, any questions about that?
So the pain is aggravated by seated position, right?
Yes, aggravated. Yes. Seated and lying position where patient will have pain. Yes. You bend forward, it's an නැවෙනකොට අඩු වෙනවා. Yeah. පිටිපස්සට වාඩි වෙලා ඉන්නකොට වැඩි.
So what about NSAIDs and steroids?
Steroids වැඩි පාවිච්චි කරන්නේ නැහැ. Colchicine is preferred. You can use NSAID sometimes. කලාතුරකින් steroids පාවිච්චි කරනවා, especially with autoimmune sort of thing, like say SLE or something related pericarditis, then steroids are used. But usually colchicine, NSAIDs තමයි commonly පාවිච්චි කරන්නේ. Okay, right. Now here we come to some of the other important pericardial diseases. So first thing is pericardial effusion. What are the features of a pericardial effusion? Right. So, pulsus paradoxus. Now what is that? Now pulsus paradoxus is this, right? So pulsus paradoxus is where, now look at this carefully. Where is this? Right. So what happens is, say cardiac tamponade or a large pericardial effusion, right? Cardiac tamponade or a large pericardial effusion. right? Let's take that for example, right? Now, when there is a large pericardial effusion around the heart, the pericardial sac is relatively tight, right? That is the main problem here, right? The pericardial sac is tight. What happens when you take a breath in, right? When you take a breath in, inspiration, as you know, there is negative intrathoracic pressure. Ne? So, inspiration, when you have a negative intrathoracic pressure. What happens there is you have filling of blood into the right ventricle. Ne? Filling of blood into the right ventricle. Now, because the pericardial sac is full of fluid, what happens is the heart cannot get any bigger, right? The heart doesn't get bigger with this filling. What happens is that in inspiration, what happens is this septum now is shifted onto the left side, right? Because blood is filling onto the right side, right? The pericardial sac is full of fluid and the heart cannot get any bigger. So what happens is the septum, right, is pushed onto the left side, onto the left ventricle. Right? Now what that causes is, now the left ventricle is smaller, right? Left ventricle is smaller now, and the filling of the left ventricle and the output of the left ventricle is compromised because of this, right? So you see a drop of the blood pressure during inspiration, right? So there's a drop of the blood pressure during inspiration. So that is called pulsus paradoxus, right? Pulsus paradoxus. So because the tight pericardial sac, due to inspiratory filling onto the right side, the heart cannot enlarge because the pericardial sac is tight around it. So what happens is the septum is deviated onto the other side, right? Septum is pushed onto the other side, compromising the filling and the cardiac output of the left ventricle. Right. So what happens is pulsus paradoxus is seen in large pericardial effusions and also in cardiac tamponade. Right. Another feature that you see in large pericardial effusions is that, or in tamponade, is that you see, you see electrical alterance. Now that's an interesting concept. What electrical alterance means is that the ECG complexes change. Size of the ECG complexes change. ECG I can't remember. Here. Right? So you can see method ECG, ECG QRS complexes, they change in size. Right? So that is electrical, let's call electrical alternance. In the pericardial sac, heart right? So that is what happens, because he is sort of swimming in fluid, it sort of floats and moves from side to side. So the electrical complexes, they are smaller, yes, but they also, the complexes are smaller, but also the height changes because the heart is moving around in the pericardial sac, or floating around in the pericardial sac now, right? So that is electrical alternance. Electrical alternance. This is what a pericardial effusion looks like on a chest X-ray. Right? Okay. Right. So that is pulsus paradoxus and electrical alternance. Any questions? So large pericardial effusions, the patient will have pulsus paradoxus, electrical alternance, right? What happens in cardiac tamponade is, additionally, they will have a low blood pressure as well. And you can't hear any hearts. Cardiac tamponade can set so much stress that the left ventricular output, make a heart then septum එක deviate to left ventricular output එක හොඳටම බහැලා then there is no cardiac output. The blood pressure starts falling, right, in cardiac tamponade. So you have to immediately relieve the pressure, right? You have to immediately relieve the pressure. Right. Now the last thing is to talk about is something called constrictive pericarditis. Constrictive pericarditis. I'll show an X-ray of this. So here you can see that there is a calcification in the pericardium. So here the pericardium is so thick and calcified. That is what you call constrictive pericarditis. The pericardium is thick and calcified. In Sri Lanka, very, very common cause of constrictive pericarditis is tuberculosis. So that is right. So this is different from a pericardial effusion or acute pericarditis. Constrictive pericarditis, the pericardium is thick and calcified, right? Very thick and calcified, right? It's like a wall around the heart, in other words, wall around the heart. Hari. And there is an interesting sign called Kussmaul sign that you get in constrictive pericarditis due to a very important reason, right? Very important reason. Right. Okay. What Kussmaul sign is that the JVP or venous pressure goes up during inspiration, right? Venous pressure goes up during inspiration, right? The main reason for that is that because the pericardium is very rigid, it's like a wall around the heart. Because of that wall, the heart does not see the negative intrathoracic pressure during inspiration. So when you breathe in, you get a negative intrathoracic pressure. It's not transmitted to the heart because of this rigid wall-like thing around the heart now. So usually what happens is the right ventricle, because of that negative pressure, the right ventricle fills up during inspiration. Then during inspiration, now the right ventricle cannot fill up because it does not see the negative intrathoracic pressure because of that wall. Then there is venous back pressure because the right ventricle is not filling up. There is venous back pressure, and that causes elevated JVP. You can see the JVP going up on inspiration. So this is called Kussmaul sign. So this is a feature which is sort of not specific but very suggestive of constrictive pericarditis, where there is a wall around the pericardium and the negative intrathoracic pressure is no longer transmitted to the right ventricle. So it does not see the negative intrathoracic pressure. So it cannot fill up during inspiration. So what happens is venous back pressure causing an elevation in the JVP. That is called Kussmaul sign. Kussmaul sign. Another interesting thing is that another interesting thing is in constrictive pericarditis, because of this ball-like thing, heart you can hear the sound when the heart enlarges with heartbeats. That is called a pericardial knock. Duk gala heart එක වදින සද්දෙත් ඇහෙනවා. So ඒක නිකන් ආසාවට නිකන් ඉගෙන ගත්තර කමක් නැහැ. හරි pericardial knock කියලා එකට කියනවා. Right. So Kussmaul sign is an important sign that you need to know. Hari. Okay. So yes, that is right. Antimeka pericardiocentesis is the treatment for cardiac tamponade. Yes. So you have to do pericardiocentesis. I told you because in cardiac tamponade, it's such a compromise on the left ventricle that the cardiac output and blood pressure drastically falls. Right. So you need to relieve that pressure and put a needle and take the blood or whatever out. Right. So that's a brief introduction on pericardial diseases. ඊට වැඩි නෝක දැනගන්න දෙයක් නැහැ because වැඩි වුණොත් එක MCQ එකක් අහයි ඕකේ. But of course, arrhythmias, you can get a few MCQs. That's why I spent a little bit more time on that. Okay, and SCQ it is on AF. Yeah. And warfarin ගැන අහලා තියෙනවා. ඒ ටික පොඩ්ඩක් ගන්න. මේකේ ඕන උත්තර ටිකට ලියන විදිය තියෙනවා. But please try to attempt it and we will discuss it later on as soon as we finish our MCQ class. Right. Any questions about today's discussion? ප්‍රශ්න මොනවා හරි තියෙනවද? Oh, there is one more sphere. Sorry, where is that? මොකක්ද ඒ sphere එක? ඒක මේකේ presentation එකේ තිබුණේ නැහැ නේද? Hold on. මොකක්ද paper එක? This one with the patient coming from Africa අරක මේක නේද? Right. So another feature of, so the answer there is constrictive pericarditis 4. So another feature of constrictive pericarditis, the reason is a bit complicated and I don't want you to worry about it too much now. You get significant negative waves in the JVP as well. So apart from the Kussmaul sign and the pericardial knock, another feature would be this sort of steep negative waves in the JVP. There are X descent, Y descent, you know the negative waves in the JVP are also exaggerated in constrictive pericarditis. හරි. සමත් හෙට වෙලාව කීයද අපි කිව්වේ?